Thanks so much, Juan. Hi, everyone. Welcome. My name is Kirsten Forsyth. My pronouns are she, her, and I'm an associate director on NASTAD's drug user health team. Really glad to see everyone today. We're here for part two of a webinar series hosted by NASTAD, but really led by our friends at the National Coalition to Liberate Methadone. The webinar series is called Past, Present, and Possible Futures of the Methadone Treatment System. 2 weeks ago, we gathered for part one, which was about the history of the methadone treatment system and kind of talking about where we've come from. And today we'll dive a little more deeply into where are we now? What does the current methadone system look like? What have recent events looked like, and what changes have those caused, such as the COVID-19 pandemic in the methadone treatment system. And then we are excited about future webinars that will look at possible futures and reforms and changes that we might be able to advocate for or expect in order to make the methadone system more in line with our values around person-centered care, around harm reduction, and patient autonomy. Glad everyone is here. Let's see if there's any more housekeeping items to get to. Juan mentioned that we do encourage folks to ask questions in the chat, and we'll be gathering those and saving them to put to the panelists at the end. This will include a little bit of presentation and also panel discussion amongst our esteemed panelists gathered here today. And before I introduce the panelists and our moderator, I do want to acknowledge that we are able to support this webinar series with funding from the Opioid Response Network, which is a SAMHSA initiative that is focused on assisting states, organizations, and individuals by providing resources and technical assistance to address the opioid crisis and stimulant use. And technical assistance is available across evidence-based prevention, treatment, recovery, and harm reduction. You can Google Opioid Response Network and it'll bring you to their website. And in the top right corner, you can click on a button to request free technical assistance. And NASTAD is one of the TA providers with the Opioid Response Network. So we are really pleased to be in partnership with ORN and for that support to host this webinar series. So let me get to the fun part, which is introducing our panelists and moderator for the day. So we have as our first panelist, Dr. Leslie Suen, an assistant professor of medicine in the UCSF Division of General Internal Medicine at San Francisco General Hospital, and a member of the board of directors of the National Coalition to Liberate Methadone. Dr. Suen works as a primary care and addiction medicine physician and health services researcher. Her research focuses on using implementation science to improve health systems, policies, and outcomes for people with substance use disorders. We also have Dr. Rachel Simon, who is a primary care and addiction medicine physician at Bellevue Hospital in New York City, and a clinical assistant professor of medicine and psychiatry at NYU Grossman School of Medicine. Part of her clinical responsibilities includes providing care to patients at Bellevue's opioid treatment program. She completed her internal medicine and addiction medicine training at Massachusetts General Hospital. We also have Caitlin Small, who is a mother of 3 and a person in long-term recovery who uses substances. She has been a methadone patient and advocate for over 7 years and has lived and living experience in mental health, poverty, including homelessness, domestic violence, and teen parenting. Caitlin earned her bachelor's degree in psychology from Elms College and has been a direct service provider for over 15 years in inpatient, residential, outpatient, and outreach settings. Caitlin is a harm reductionist with a passion for dual diagnosis and comorbidity and trauma-informed care. Caitlin currently works as a mental health counselor at Mira Vista Inpatient Psychiatric Hospital. as a counselor for CHD's mobile crisis line, and as a recovery specialist for MHA's dual diagnosis residential facility. And Caitlin dedicates her life and work to being a voice for marginalized populations. We also have Irene Garnett. Currently, Irene is the Grants and Communications Coordinator at Cochise Harm Reduction, a grassroots syringe services program and mobile outreach / harm reduction organization on the US and Mexico border in Bisbee, Arizona. Her lived experience includes being on methadone for 13 years. Irene has been a part of the Drug Policy Research and Advocacy Board in Arizona since 2021, contributing as a co-investigator and co-author on multiple research projects and articles related to accessing harm reduction care and medication-assisted treatment. Additionally, Irene has been a panelist at the National Coalition to Liberate Methadone Conference, the 2024 Drug Policy Alliance's Reform Conference, and the 2024 Integrated HIV, Hep C, and STI Symposium. So we are thrilled to have this group of panelists with tons of experience across lived experience as advocates, as providers, researchers, and professionals in many contexts. And finally, I will introduce and then hand it over to our moderator for today's panel. And that is Kate Roberts, who's an LCSW and the Deputy Director for Behavioral Health Policy at Aurora Health Group, and a licensed clinical therapist with almost a decade of clinical experience working with substance use. Kate is a behavioral health and drug use research expert who has focused her career on supporting healthy systems engagement in harm reduction-based substance use screening and treatment, with a focus on structural factors that impact women and gender minorities who use drugs. And we've been fortunate to have Kate as our kind of main contact and co-conspirator with the National Coalition to Liberate Methadone to envision this webinar series. So I'll hand it over to you, Kate.
Thanks so much, Kirsten. As Kirsten has already stated, in our first webinar, we kind of did this like big history of how we got here with methadone, what were the policies, why is it in OTPs, and kind of looked at the federal landscape. So with this one, we're going to dive in a little bit. So first, I would like to ask the panelists, particularly, how does the methadone landscape shift and change when you look at it in different states, in different OTPs? Like, help people understand why methadone treatment can look so different depending on where you are. I'll pass it to Leslie first.
Sure. Can everybody hear me okay? Okay, yes. So I think, first we have to think about zooming out that methadone regulations were put in place in the Nixon era, so in the 1970s, and they have largely remained unchanged for the past 50 plus years. And that is wild to me. My background is as a physician, and I can't think of any other example in healthcare and medicine where something that we were doing in the 1970s, we are still doing today and is still considered the standard of care. And so just to put that context, like this system was put into place 50 years ago. And what that system looks like is, I just wanted to share a couple of slides just to kind of illustrate the point. 1 second, sorry. Is the methadone regulations are really built to be complicated from the get-go. And the reason for that is, so let's see. If you think about who makes the rules for methadone, we have the federal agencies such as the Substance Abuse Mental Health Services Administration. And so that is part of the sort of executive branch of the government under the Health and Services Agency. And then we also have the Drug Enforcement Administration, or the DEA. And then they really set the sort of what's the baseline for all regulations that all states have to follow when it comes to methadone. And then on top of that, we also have state level agencies, so state health departments and state opioid treatment authorities, also known as the SOTAs. And each individual states can add on additional layers of their own regulations. In addition to that, individual clinics tack on their own rules. And so there's just this really complex network of regulations that a lot of, imagine being a patient and trying to navigate through this complicated system and knowing that this is not a bug, but this is a feature. Like this is the system by design. Just one example of how different states can do things differently. So if you look at, for example, counseling. So under federal regulations, there are no federal minimums of requirements for counseling. And then different states can tack on. So for example, in Tennessee, they do require at least 2 sessions a week for at least 30 days. And then people can move on to once a week in the months 1 through 4, and then twice monthly through months 4 to 7, and then monthly onward. And you can imagine, like, this is a really complicated schedule for people to follow, depending on, their life schedules, their jobs, their caregiving responsibilities, and being told you have to follow this guideline of counseling because of a state mandate when there's no really a federal mandate. It raises a lot of questions. And then secondarily, there's also drug testing. So at the federal level, there's a minimum, there used to be a minimum requirement before COVID-19 that people had to have at least 8 random drug screens per year. So that was the minimum. And then states like New York actually added on additional drug screens. So in New York, they require weekly testing. So a 1 test per week for the first 3 months, and then bi-weekly afterward. And then they can graduate to monthly testing if they have 3 months of negative bi-weekly testing. So again, very complicated state regulations that are hard to follow, and also add on a lot of restrictions that are not entirely supported by evidence that actually improve outcomes. So I'll stop talking there.
Awesome, thank you. That's really helpful context because I can't think of any other medication that also requires that much work to stay on a medication for treatment. Okay, so now that we have this context of how varying that this can be, I think it'd be helpful to understand what is the process of being started on methadone. And I'm so glad that we have 2 different kind of buckets here of, like, we have the providers starting people on methadone and the people who have been on methadone. So let's start with Caitlin and Irene. Would love to hear your experience of what it was like getting started on methadone.
Sure, thank you so much. I guess I'll start with just saying I started on methadone in 2016. And so obviously prior to COVID and everything changing. And for me, getting on the program was harder than just going out and getting high, right? And so that was like the number one barrier. Was I was sitting in a detox and I had gone through my spin cycle, and everything was, out of my body. I had been brought down on everything that I was going to leave with. And they told me that I had to wait 3 weeks until I could have like my methadone appointment. And so my options were to either like now go out with like my tolerance in the dirt and potentially overdose, or remain clean and sober for this period of time without anything, and withdrawing with 3 kids, jobs to do, and all the things. And so that was like the initial start of what methadone was going to look like for me. And then after I finally had gotten into the clinic, it was like I had to show up the first day for a 2.5-hour long, had to be sick, had to go through every question in detail. Couldn't tell you to this day what the hell we talked about because I was so not in my own right mind that I had no business doing anything of the sort. But yeah, that's what it was like. And I still didn't dose that day, right? So I had to wait until the next day when I was able to see the medical provider, and then I could dose. And so that was like just starting on my measly little amount that certainly wasn't going to touch my fentanyl addiction. I was an IV user of a bundle a day. And it was just to the point that like that wasn't going to be something that even touched it. And so that was just getting onto the program. Starting into the program was a whole nother batting cage of different things that I had to jump through the hoops of. I dosed every single day for 6 years straight of my life, including holidays like Christmas, having to like run to the next town over with no vehicle at 5 a.m. before my 3 kids under the age of 10 woke up to see the Christmas tree, because could you imagine if I missed that? Like that's what Christmas is all about, right? And so, having to like fearfully get there, get my dose every day, you know, snow, sleet, shine, no transportation. I was homeless at the time. So all of those things just kind of made it nearly impossible to stay on the program. They used the 8-point guidelines, and because the clinic was able to kind of decide what that meant and interpreted that, I was homeless. And even though I was lock and key in an apartment because I was a family and I had like my own apartment, a bathroom, a lockbox, all the things, just being homeless made it so that I qualified for my medication not being able to be safely stored. And I had a partner in recovery, so they said that the divergence, because it was possible he'd get my medication, I also didn't qualify for, right? So there was these things that, like, no matter what I did, and no matter how clean and sober, or, you know, my tox screens came back, for 4 years straight, I had clean toxicologies with, you know, all negatives. I had positive for marijuana because in the state of Massachusetts, if you have a medical card, you can use cannabis. And so I used that for my anxiety and PTSD instead of some heavy benzos that I was prescribed. Decided to use cannabis, and that was the final straw. So because of that, even though everything else was negative for 4 years straight, I still had to dose every single day. And so it was challenging. It was nearly impossible. There was many days that I, you know, wanted to give up. God forbid you miss, and then they bring you down. It was just, you know, and on top of all of that, you touched on it earlier with the counseling. And, you know, at our clinic, it was an hour a week counseling and an hour a week group. And so that was added on to what DCF's plan for me was, with all their requirements of counseling and all of their groups that I was going to attend. And so, like, getting a job, getting out of homeless, all of those things were like completely dampened just because of trying to gain access to life-saving medication.
Thanks so much. And for those who aren't aware of what the 8-point criteria are, I stuck that in the chat. Irene, I would love for you to share your experience as well.
Yeah, thank you. And touching on what Caitlin said, I totally agree that it can be a lot more difficult to get into treatment than to maintaining your habit. Although I've been on methadone for about 13 years. I've been to 3 different clinics in that time period. It was kicked out of a couple. So when I started, I remembered they didn't have any appointments. So I finally made the decision that this was really necessary for me. I was working at the time, and they didn't have any appointments, but they said you could show up at the clinic at 3 a.m. every morning and line up, and whoever was in line at first, depending on people who missed their appointments that were scheduled, you could get seen. So people would just do that day after day. It was in a dodgy part of town. I went there at 3 in the morning. I was able to get seen at this first clinic. Like Caitlin mentioned, you know, you sit there for like 2.5 hours of questions and things like that. I was able to dose that first day after going through those hours of waiting and questions. But they only start you out at 30 milligrams. So I was asked to leave that first clinic because of continuing to have abnormal UA screens. And also, like Caitlin mentioned, with the counseling and the group requirements, something that really struck me was how little concern the clinic staff would have about your priority to have a job and to maintain a job. And, you know, I heard over and over again, recovery is your first priority. That's what comes first. It's like, you know, I got onto methadone so that I could keep my job and not get sick having to try and maintain a pretty high habit. So because of testing for certain substances, they would make you go to certain groups, like if you tested for methamphetamine or cocaine and things like that, and those would be at 10 in the morning, you know, not conducive to a work schedule at all, and they were mandatory. Like I mentioned, so I've been to 3 different clinics. I'm currently at one that's much more of an office setting, and is perfectly fine. It's really interesting to see those requirements for different states. Like at my clinic, you have to have drug screens monthly. I thought that was a pain, but seeing how New York's doing it, I mean, gosh, every week. at least in the beginning. But in the 13 years I've been on methadone, I've had to dose in person daily for a good many of those years. There was a time when I had 2-week take homes. That was the max I ever got, but then I would drop back down. So yeah, it's tricky.
Thanks so much to both of you for even like highlighting the differences in starting on methadone, and that depending on the clinic that you're going to can really change and impact what your process looks like. I want to turn to Rachel, who works in an OTP, to discuss like what is the physician side of people getting on methadone, or like the clinic side.
Yeah, thanks so much, Kate. And folks can hear me, I hope. Yeah. Okay. And thanks, Irene and Caitlin, for sharing your experiences starting on methadone. So yeah, I work as a doc and an OTP. And, you know, on one hand, I will say that I feel so grateful to be able to offer people methadone. It's really the most remarkable medication that I know of. I mean, there's really no other medication that I can prescribe that cuts mortality in half by 50%. There is no other medicine that comes close. The next one is Lipitor after someone's had a heart attack. And unlike Lipitor, methadone so clearly changes somebody's life. I mean, someone's taking a statin, we don't really see that change day to day necessarily, but if someone's on methadone, I see them come in 2 weeks later and they've been able to eat, sleep, take a shower, call somebody they love. I mean, it's really a remarkable thing. So as other people have said, it's in a sense like a miracle molecule, and I feel grateful to be a part of that. And then there's the but, right? There's the big but, which is that for every person that I help get started on methadone, there are thousands more that have been unable to make it to the clinic because of the way methadone is dispensed in this country. You know, we make it so challenging to start at the clinic and then to stay at the clinic, whether it's things like daily dosing, mandated counseling, the commute time to get here, all the ridiculous hours of operation of the clinic. So yeah, so there's the big but to being on methadone. And I think stories can be helpful, and Caitlin and Irene sharing your story is so helpful. One story, I mean, there were many sort of straws that broke my camel's back of getting into the Liberating Methadone Coalition, but one that I won't forget was in January 2022. It was a Saturday, and I woke up and I was commuting into New York City at the time, but I woke up, it was a Saturday. I didn't have to go to work in the OTP that day. And I was like, thank God I don't have to go in. I really can't even get out my front door. And then my heart just sank into my stomach because of all the patients that I know that had to find some way to get into clinic when the trains weren't running, when the buses weren't running, when they would really had to risk their life to get into clinic, and then also risk their life when they are not getting into clinic and not dosing and having to access a really deadly supply. So there's that. And I mean, from a, you know, getting started on methadone perspective, other things that I would like to highlight are, there's like 3 big things that I think about. 1, it's you have to find a clinic. 2, you have to schedule an intake appointment. And 3, for the most part, you have to have an ID. So I want to go through those 3 things quickly. First is like finding a clinic. It's so important to note that only 20% of counties in this country have an OTP. That means 80% of counties do not have an OTP. And thought about another way, Dr. Chaudhry and colleagues published an important paper looking at drive times to different OTPs. And they looked at the 5 states with the highest overdose rates. And they found that in urban areas, on average, it took 37 minutes to drive one way. And in rural areas, it was 49 minutes. So basically, in these areas of really high need, it could take 2 hours to get to a clinic and back. And when you need to work, when you have to care of your kids, this is just like a totally impossible ask. So that's one, just like getting to a clinic. The 2 is scheduling an intake appointment. I mean, the clinic where I work, you can get an appointment in a few days. There are clinics in New York City where there's walk-in same day hours, which I think should be standard of care. But in most of the country, you have to wait weeks to get an intake appointment. When we're dealing with this overdose and polysubstance crisis, is really just unacceptable. And then the third thing, an ID. Lots of clinics require an ID, like around 10 states actually mandate that to get enrolled in a program, you need a government issued ID. When we know that folks experiencing homelessness, folks who are undocumented, folks just recently released from incarceration, so many different groups of people, that is just like a, you know, that will prevent people from joining. Yeah, I mean, on the admission day here in the clinic I work with, it takes hours. Yes, you have to meet with a counselor, you have to meet with me, you have to meet with a nurse, you have to get blood work here, or an EKG, you know, electrocardiogram to look at your heart. There's a bunch of stuff, so it takes a long time. But yeah, I could keep talking, but I'll stop.
Thanks so much, Rachel, for sharing that. And the paper that Rachel talked about from Dr. Jodry, I stuck in the chat, which is really, I think, interesting and helpful. So we talked about what it takes to get on methadone, which, you know, sounds like, barring a miracle, like a shit ton of work. Now I would like to talk about what's the process of staying on methadone. And Rachel, I actually want to start with you first on this. I know that you've done a lot of work with like the day-to-day operations and the guest dosing. So like, what is the process of somebody for you like staying on methadone?
Yeah. So in anticipation of this question, I thought of like 6 things that I want to highlight. So I'm going to pull up my little cheat sheet and remember them now. But so there are certain things that it's important to highlight about being, you know, being a patient in a methadone clinic. The first one that I alluded to before is the hours of operation. Most clinics are open like 5 to 10, like really wee early hours in the morning, like 5 to 9. There's one clinic in the country in Arizona that's 24/7. And, you know, there are a few that have extended hours, but that is few and far between. Only 8 states, I think. Pew Trust did a really good study review looking at all the different state requirements, but only 8 states require that OTPs be open outside of business hours. So first is the hours of operation. That's something that's important to know about the logistics of an OTP. The second is, so request for dose schedule changes. Let's say someone is on methadone and is told, you know, has a dosing schedule of coming in 6 times a week. Let's say, God forbid, like a loved one out of state gets acutely sick and they have to travel. What are they going to do? I mean, they have to get their methadone, right? So they're making this decision between going to take care of a loved one or staying safe themselves by getting their methadone. So that's another thing I had, you know, you can submit a request for additional take-homes, at least at the clinic I work in, you can, but that's not going to happen overnight. No one's going to deliver your methadone to where you're staying so that you could travel. That's the second thing, the pickup schedule request. The other thing is dose changes. So let's say I'm on 80 milligrams, but I feel sick in the morning. I'm dreaming about using, I feel uncomfortable. The 80 milligrams is not working for me. I want to increase my dose. At the clinic I work in a progressive clinic. I'm grateful for that. But the clinic I work in has an MD here all the time. So you could talk to them and you could almost, you know, immediately get a dose change. That is not the norm. Most OTPs are staffed by docs that are like, you know, this is their like retirement gig. They're in the clinic like half a session, maybe once a week or every 2 weeks, and they, you know, complete all the dose change requests then. But in the era of fentanyl, when every day is like very, very important, like these dose change requests should be happening, you know, immediately. That's the third thing. The fourth thing is urine toxicology. So as was mentioned, you know, New York used to require weekly urine toxicologies, basically. Thankfully, our state SOTA is now aligned with the new federal guidelines. So it's like 8 a year is basically, and our clinic has changed. But yeah, you have to submit very frequent urine toxicologies. And one thing that really blew my mind that doesn't thankfully happen in New York, or clinics I know in New York, but does happen around the country, is this concept of the urine toxicologies needing to be observed. There are a handful of states that require observed collection of urine toxicology. It's almost always done with a camera, but can you imagine, like, what is more dehumanizing and an abuse of power than having your urine collection be observed? That just feels totally awful. Okay, so there's urine toxicology. Counseling. We've talked about how even though the federal regs don't mandate counseling, they just require that it's made available. Many states do mandate it and tie even dose request changes or take homes to counseling attendance. And I've heard stories like a friend of a friend in Missouri who's on methadone, who really like had to travel an hour to go to a mandated coloring class, like crazy stuff. And I think that's it. Maybe I missed one, but those are some logistics of being in an OTP that don't often get publicized, but I really do think affect people day to day.
Irene, I'm going to turn to you now. I know you're in Arizona and have worked a lot, both like in the policy of Arizona, as well like of your experience having methadone. Would love to hear, you know, from your perspective, what it's been like in your location to stay on methadone, what's been helpful, what's not been helpful.
Sure, yeah, it's, you know, like with anywhere, and as mentioned by Dr. Simon, with only 20% of counties even having an OTP to attend. One story I can share is I accepted a job in a city in Bisbee on the border that didn't have any clinic. So I couldn't take that job. The closest clinic, and I was having to attend the clinic like 4 times a week. So it was going to be like a 50-minute drive each way. So anyway, I'm based in Phoenix now. Luckily, there are a lot of, not a lot, but there's a fair amount of clinics in my area, and I am familiar with the 24-hour clinic. I've been there, and that was a revolutionary step. But to your point about the hours being so crazy, and again, it ties back to Caitlin saying how they make it so difficult to get treatment versus staying on your drug of choice. Because I mean, to require attendance 6 days a week, and then like Monday through Friday, say at my clinic, it's 6 a.m. to 11 a.m. But on Saturdays, it's only open from 6:30 to 9. You know, so it's like even on the weekends, you have to get up even extra early. So I guess I'm fixating on that onerous requirement. But in Arizona, I belong to this group called the Drug Policy Research and Advocacy Board that Dr. Beth Meyerson started out of University of Arizona, and there's members all around. But our state SOTA is part of that group, and so she's been really open to being educated about the new policy recommendations that came down from SAMHSA, and has decided to move forward with adopting those. Although it did look a little bit touchy because different states, their SOTAs can have different backgrounds. Well, and I probably don't need to go too far into the whole SOTA thing, but I'm lucky in Arizona that our SOTA is on board with adopting these regulations. But as has been mentioned, you know, first you have the federal recommendations, then it can get narrowed down even further by the states. But really, the clinics are their own independent fiefdoms. They can do whatever they want. And so the issue in Arizona that I think is going to be really problematic with clinics adopting these recommendations for allowing 28 days of take homes is that they get reimbursed at a higher rate from insurance companies for in-person dosing. So for each person that doses in person, they'll get like $15 reimbursement versus $4 if they're take homes. I mean, the largest methadone provider in the state is a for-profit company. You know, we'll see. I mean, I have heard some rumblings that they will be adopting the recommendations, but who knows? So that's definitely an issue right there that needs to be managed. I don't know if that's the case in every state, but that's specific to Arizona with the payment issue.
Thank you so much. And as a reminder, Emily Dufton last time spoke a lot on the privatization of treatment, and I know has a book forthcoming on this. Caitlin, you are in rural Western Massachusetts, so curious how that shapes your experience.
Yeah, absolutely. When I first, so I am on my second clinic now, and so my first clinic that I was speaking about before was about, it was We had to take the PVTA bus, so it was about an hour and a half. And on Sundays, the PVTA bus doesn't run. And so we didn't have transportation, but I had to still dose. We dose 7 days a week. And so I had to make sure that I found transportation every Sunday. And, they had to come to me and then get me about 50 minutes away, just about an hour away, and then get me back. And so convincing people to do that when you don't have much money to your name isn't very easy. And so it was hard. It was hard just to get, where I needed to be. But the clinic that I was on also had really rigorous rules around times. And so, as mentioned before, with like the time periods in the beginning of the day that, are nearly impossible to get to, they were also very rigid about like appointment start times and groups. And so I remember one day, my kids were in like the 3rd grade, and I had to leave my son bawling his eyes out on the sidewalk, like couldn't even like console him, had to like leave him with the teacher and run, because I knew that if I didn't get to my clinic in like the next 15 minutes and I didn't walk through that group door, not only would I miss group, but I wouldn't be able to dose for the day. So their requirements were like, you're here at 9, and I did leave my kid, and I did get there, and I got there at literally 9:02, and it's not an exaggeration, and I didn't dose because they didn't allow me to dose that day. They held my dose from me. You had to be there like on the dot. And for people who, I don't know everywhere, but in Massachusetts, public transportation doesn't run on the dot. And so it was very tricky to get places and to be to these mandated appointments. And as said before, like, if you missed one appointment, that would be marked against you. And those were the clinic rules. But as I also mentioned, there's like this layer of then who the clinic reports to, right? And so whether you have probation or DCF or these other types of cases, it matters in those stances, because then if you like miss a counseling appointment, it's like, oh, she's not going along with treatment, or she's missed X amount of appointments out of 5 of the impossible ones we've made, right? And so like it just like really like affects, like it makes you look even worse really than, and you're trying as hard as you can. And so there was really a lot of layer there that I had to deal with. And just touching really quickly on being able to like go on vacation or leave if you had somebody sick across the country or anything like that. We had to give a 90-day notice to have any type of guest dosing anywhere else, to be able to get travel bottles. The first ever travel bottles that I ever got in my entire life of dosing on methadone was for the Liberate Methadone conference last year. And that was not anything to do with the clinic that I was at or anything in that shape or form, right? So like I was able to have access to the things that I needed. Thankfully, I was in a place at that point where I was at the clinic that I'm at now. And so they were like, we're doing this, let's do it like in a times week. I had gotten everything lined up. And then on the Liberate Methadone side of things, they were also helping like orchestrate making sure everybody had methadone. And so that was the first time I ever really anything be productive in that way. We weren't able to go, we didn't leave, our hometown. We didn't go anywhere. It didn't matter who was sick. It didn't matter what was going on. We had to stay close by. And even now, so now I live in like I live in like the Berkshires of Massachusetts, which is like up in the mountains. And so the clinic that I go to now, which is very, very advanced, very, they're doing an amazing job implementing things. That's an hour away from my house now. And so I have to, still travel. Thankfully, I have bottles and things like that. But the difference in their requirements and how recovery works, right? At the clinics where it was, this is how you have to do it. It was very like abstinence based only. My recovery was not my recovery. It was my clinician's recovery. It was my clinic's recovery. It was everybody but my recovery, right? It was what everybody else needed and wanted of me. And then once I got into this new clinic where it was like, here, the ball's in your court. Like, how much counseling do you need? And where do you want to go to group? And how can you advance your life here? Right. And like, we started having these conversations about like harm reduction and, maybe not necessarily being completely abstinent and all of those not logistical things, right? All of those relationships with a counselor and those interactions that you have are things that you have to incorporate in staying on a clinic, right? Because it's very challenging. My experience at a clinic where my recovery was all theirs, my life for that period of time was unmanageable. Even though the drugs were put down, I was doing, the doctors would tell me that I was like the poster child for recovery. And I'm like, then why am I still homeless and I can't do this, right? And it's because I couldn't move forward. I couldn't advance in my life in any way. And so now being able to have, a different clinic and in a place that things are a lot different, and I'm able to have my own recovery, my life has improved. Like, I can own my recovery. There's nothing done in secrecy, right? Like, chaotic use manifests in the dark. And when you can't have conversations with your counselor because you're not sure if they're going to report it back to DCF, or if their idea of, a parent using drugs is automatically neglect, right? Like, there's all of these stigmas and biases that clinicians can hold that like really stronghold your life when you're in a program like this. And so those were all things that I constantly had to be aware of. I constantly had to be looking over my shoulder, constantly making sure I was stepping up to the beat. And that was on top of navigating brand new recovery, like feeling feelings for the first time, and like trying to handle my partner who's now clean and sober, and my 3 kids who hate me for every reason in the world, right? Like all of these things that were really hard and heavy. And I'm like playing this dance with the clinic, right? And so, yeah, that's what I think of when I think about like the requirements of actually staying on and showing up for the clinic in my recovery.
Yeah, and that's so helpful. And what I hear in a lot of this is like the levels of surveillance that happen, whether it's, from you having to surveil yourself and internalize that to like the clinic staff. And I'll add, as a trained social worker, I mean, like that's how most social work programs train people. And it's a lot of social workers and case managers, like who are the gatekeepers to this, of holding people to a standard that is like nothing short of, I think some have put it like stigmatizing and paternal. Okay, so COVID happened, in case anyone is aware, and it forced this interesting shift in methadone treatment when the whole world shut down and kind of like forced clinics' hands in being creative. And so I would love to start with Leslie and Caitlin. I know you both have done a lot of work on like the shift of COVID-19 and methadone. How did that shift, particularly take homes? Like we've talked a lot about take homes, they've been hard to access. How did COVID-19 shift that?
Yeah, I'm happy to kind of give an overview of just like what exactly happened on like a nationwide level, at least. And so we talked a little bit about the 8-point criteria that was mentioned, and then Kate also put this in the chat. But I really wanted to highlight what Caitlin said earlier about how a lot of these 8-point criteria were very subjective. And so people had to meet all 8 criteria before they were allowed take homes prior to COVID-19. And you can see, there's a couple of them in here that are open to interpretation, particularly this number 5, stable home environment and relationships. So what is counted as a stable home environment? What is counted as a stable relationship? And then also what is considered acceptable length and time in treatment? These are all kind of like very vague terms. That is, again, kind of open to whatever the clinician or the doctor at the clinic decides it to be, and can also lead to inequitable application of treatment and people not getting access to take homes, even though they may fit all criteria and may be an upstanding model patient. And so during COVID-19, as you can imagine, 2020 was a very chaotic. Oh, sorry. Actually, one thing to also add on is in California, where I am, people also, the state also added on additional take-home requirements. So if people needed take-homes beyond 6 days per week, they needed at least 6 months of toxicology that was negative for illicit drugs and positive for methadone. The clinic had to have a callback procedure in place. So like bottle counts, to check on, quote unquote, compliance with medications and monitor for possible diversion. So people had to have a working updated phone number, and also must agree to comply with a callback procedure So basically, you know, it can be in the middle of the day, you're taking care of your kids or you're at your job and your clinic calls you and says, you have to come to the clinic right now so we can count your bottles. And you can imagine like that is very disruptive to people's lives. And yet that was one of the requirements if you wanted more than 6 take-homes per week. Or sorry, more than 6 take-homes per month. And then also additionally, you know, the program had to have procedures for collecting at least 8 samples of toxicology testing per year. They had to have proper procedures for handling and labeling of take-home bottles. And then also they had to have procedures in place to restrict take-homes of patients who go back to using. And so what happened during COVID-19? So SAMHSA, the Substance Abuse and Mental Health Services Administration, or the federal government, they declared really sweeping take-home exemptions in March of 2020 when COVID was happening. So they said they allowed up to 14 days of methadone take-homes if you were considered quote unquote unstable. And then up to 28 days of methadone take-homes if people were quote unquote stable. And they really allowed clinicians again to decide what was deemed stable and unstable. And so it was very open to interpretation. And yet this was the first real sort of change in policy that had been seen in decades when it came to methadone treatment. They also allowed loosened rules around the use of telehealth for counseling. So people could use the telephone or video visits to do their counseling. And then also people could start using buprenorphine and doing their intakes entirely virtually or over the phone, though methadone in a lot of places still required an in-person visit for an intake. And most countries across the United States did adopt either the flexibility on take-homes or the flexibility on telehealth. So the green states represent people who are states that did both of the flexibilities. The blue states are states that only did the take-home flexibilities, and then the yellow states are states that only did the telehealth flexibility. And basically, you can see across the board, pretty much 43 states out of the 50 states in our country did adopt some flexibility across the board. What we found, and this is national data, this was a paper in JAMA Psychiatry, and this was done using data from the CDC, done by scientists at the CDC and our National Institute on Drug Abuse, which are the leading national institutes on drug use research. And what they found is that when they looked at overdose deaths before and after these policies were put into place, overdose deaths from methadone did not significantly increase as feared after they loosened these regulations. So the sky did not fall through. The top graph shows that the overdoses in the country before and after, not involving methadone, significantly increased, mostly due to fentanyl, as we mostly know, or that we all likely know. And then the bottom graph shows pretty much flat lines before and after methadone, meaning that the rate of methadone deaths, overdose deaths, did not really change before and after the policy implementation, despite overdose deaths across the country from fentanyl increasing. And so in terms of, diversion, I think that's honestly the biggest fear that the DEA is also citing is like, what about methadone diversion? If we give people more take-homes, are they going to divert them more? So the early reports found that, it was relatively rare, though this research is relatively mixed. There was a survey of 104 patients in North Carolina across 2 methadone clinics, and they found that really only 4 patients reported diverting their methadone during the pandemic. And then there was one sort of like study, there was one study of 603 patients in Minnesota where they looked at the urine drug test for methadone, and it slightly increased from 2019 to 2020. That was significant because the urine tests were more like a little bit more likely to be negative for methadone, but the authors weren't really clear if it was like from people not taking the methadone or was because of that disruption of access during COVID, where people weren't able to access their medications after all. And so the research around diversion, what we know is that the sky didn't fall through, and there have been no research to our knowledge that has really shown diversion increased, which is, I know, what the DEI really fears. And patients really liked take-home flexibilities. They found that increased take-home doses, like studies of patient perspectives, found that they support treatment experience by improving self-esteem and autonomy. They reduce treatment burden, and they avoid negative triggers associated with clinic attendance. So One of the studies cited how going to clinic and being reminded every single day that you have, a condition or something that's not really part of your life anymore, if you've been in recovery for a long time, can still be very triggering. Like constantly reminded, like this part of your life when you want to move past it or graduate is not really a very conducive part of recovery. Some patients also express some downsides, like including disruptions of their routines and their treatment stability, though again, incidences of diversion were very rare. And then when we asked clinicians, what were their perspectives of the flexibilities, most of them expressed that flexibilities really allowed clinicians to provide more patient-centered care, improved patient motivation and engagement, and then also really reduced the burdens of treatment on patients too. And though some also express concern that less frequent contact could be destabilizing for them, and then also lead to disruptions in treatment stabilization. And I also just wanted to highlight this really wonderful study from Beth Myerson. I know, Irene, you're one of the authors, which is so cool. And this showed that this was a study in Arizona, which really showed that not everybody really experienced take homes equally. And really, it was very rare for anybody to really receive the maximum allowed number of doses. Like I mentioned before, the max number of doses during this time was 14 if you're considered quote unquote unstable, and 28 if you're considered quote unquote stable. And basically nobody received the full doses. Some and most people did receive some, but not to the extent that they could have received. And so it's just important to note that despite the policies now being implemented at the federal level, they've now been made permanent by SAMHSA, and states are starting to adopt them. Clinics and patients at the clinic level still may not be seeing these benefits because clinics may not be adopting them. So it's something to really, really important to recognize.
Thank you so much, Leslie. Now, Caitlin, I want to turn to you because I know you've also done this work. And specifically for you, like talking through like what are the barriers that you're still seeing exist to take homes, and how do you think like stigma is shaping this care?
Yeah, absolutely. And I just want to say really quickly, what I was thinking about when Leslie was speaking was I always have this running joke that during COVID-19, everything shut down but my clinic. And so while these things were happening, I still dosed daily. I still wasn't allowed, even as a not unstable patient, because of their criteria. And so I had to stand outside for 2 hours, 6 feet apart from the person in front of me, and receive my dose. And it literally took about 2 hours a day in that line. And so just to like move through it and to get through everybody. And so while I had to do that, all of my other recovery resources plummeted, right? Like all of the doors shut at the 12-step programs, my peer recovery center shut down, everything fill-up wise and recovery wise had ended. And so for me, that became really challenging during that period of time. The clinic that I'm with now actually has adopted a lot of really good things when it comes to the new final rule and getting take-home bottles to people. They've created a tool that they use to really understand if people are experience a substance use disorder or not, as that's like now one of the criteria, and that's the way that it's worded. And so by doing like going through the DSM-5 and having like an open conversation with your clinician and being able to have an open dialogue about your use, they're able to decide whether they think that you have like the diagnosable DSM-5 substance use disorder. And based off of that, you're allowed more take home. So you can have a positive screen for fentanyl or for cocaine sporadically throughout, and you'll still receive 13 take home bottles, right? They also have at the clinic easy access to split dosing, which, at my old clinic, it was, you had to do the peak trough, you had to, weigh a certain amount of pounds. It was like this whole thing. You had to be this certain special person. And I remember when they offered me a split dose, I was like, wait a minute, I don't qualify for that. Like, like I was the doctor. I was like telling them what was going on. And they were like, no, we're telling you, like, we'd rather you have access to this at night when you're starting to feel like crap and when you're starting to have cravings than the toxic drug supply. Right. And so seeing those things was really liberating for me to know that like now my access and my care was going to be different. But like you said, there's still a lot of things that need to be, unwrinkled. Right. And a lot of that comes from what I was talking about earlier with the stigma, with being able to have open dialogues, right? I think a lot of conversations in a clinic, when you go in on using a tool like this, having a conversation after a positive screen is like very defensive. It's like, am I going to have my bottles taken away? Like you're already meeting with resistance. You're already on the defense. And so there's going to be a long time of work in progress to change that climate, right? To be able to make it so it's like, let's sit down and talk about where you're at, right? Like, are you using sporadically? Is it safe? Is it controlled? Or are you dealing with something that's making your life unmanageable, and how can we support you, right? Which is drastically different. And so a lot of it really revolves around being able to have those conversations, being able to be open and honest, and having clinicians who are trained with these new ideas of harm reduction, right? And this trauma-informed care, and this place of not abstinence-based only. You know, like I said before, when your recovery belongs to your clinician, a lot of these clinicians they believe, because that's the way they were taught, or that's the way things have been. There's been like this fear of methadone poured upon people for so many ages that, you know, there's so much misconception out there, even here in Massachusetts with the people that are working and with my colleagues. You know, there's still so much stigma. People, you know, don't go over 100 milligrams because it's too high, right? There's still so much stigma out there that really needs to be educated on, really needs to be talked about for these new rules, I think, to be able to kind of come out and be able to allow clinics to look at this without clouded judgment, and with, you know, being able to make decisions that a lot of the wording is open for determination, like we've been talking about all day. And so we really got to get people understanding the right things if we want them to determine in that way.
Thanks so much, Caitlin. I think that's really helpful to understand like how much clinic culture matters here, and how much like the people that are doing this work matter here. I'm going to throw this one out to the whole group. This came in through the chat, but why do y'all think methadone clinics make it so difficult to start and stay on methadone? I see you came off mute.
I can say one thing about it, which was highlighted by Irene, but I can say one more thing about it. It's just the financial incentives that clinics have for daily dosing, I think, is really counter to making it an acceptable place for someone to go to get their methadone. I mean, in addition to lack of access to methadone for opioid use disorder, is the lack of acceptability of the methadone treatment, as we've been talking about. And I think daily dosing is a really big part of it. And most clinics are reimbursed based on, you know, if you come in and take your dose there. So they're not incentivized to give take home. So I think that's the big issue. And I want to point out one additional thing, that it's not the methadone, y'all. It's the fact that it's methadone for opioid use disorder. If I wanted to prescribe methadone for someone with chronic pain, I could do it in my office clinic. I could send it to any pharmacy down the block, and they could go pick up a month of methadone without any questions asked. And I don't need any special license. I mean, I need my DEA license, but a physician, a nurse practitioner, a physician assistant, different types of clinical providers can prescribe methadone for chronic pain, but methadone for OUD has this carceral system that we must go through. So it's not the methadone.
And I also just want to add, like, I think the way that our system is set up is such that we are prioritizing financials, you know, profits over people. And at the same time, you know, the main thing that people fear, clinicians and directors of OTPs fear, is they fear the DEA. And because there's always the risk of, if they don't follow this rule, or if they don't follow, if they're not seen in compliance, they risk being shut down. And to them, you know, it's, you choose the lesser of two evils, where you offer a much more restrictive system that, you know, requires a lot more barriers and a lot more hoops that people jump through. And it's better than offering no services at all because you've been shut down by the DEA. And so we kind of operate in a system that is very highly surveilled and very punitive, not only for patients, but also, clinicians really have to make sure that, are constantly in fear of angering the DEA. And so, in healthcare, it's a kind of a wacky way to operate, right? Like you're constantly being thoughtful of like trying to be like, okay, how do I avoid being arrested today? And it's not a great way for anybody to improve their health.
If I could add something that strikes me about what you were saying with the DEA and the prescribing of methadone only being restricted in this way because of people with opioid use disorder, is we have substances like pain relieving opiates and benzos and Adderall and all these things that are kind of controlled that you can still pick up at a pharmacy and receive a prescription for. And yet when somebody's trying to turn their life around, by getting on this replacement treatment of methadone, that's when they make it so difficult. It's just mind-boggling to me. And yet many people, so much of the opioid crisis with the days of OxyContin and stuff was people just getting prescribed a ton of opiates. I just think that's crazy.
Yeah, and this leads me to ask, how has fentanyl changed methadone? And how has fentanyl changed maybe the need for methadone? I see nods. Anybody want to answer?
Well, it's certainly a huge crisis just in the numbers of overdose fatalities and with methadone being the most evidence-based effective treatment, it seems it should be more accessible. I realized also it seems like we haven't really talked in this conversation so much about the buprenorphine Suboxone difference between that and methadone, but I know personally I started out on Suboxone buprenorphine many years ago. I was living in New York at the time, and but my habit was such that it didn't really touch it. And I realized that that's kind of the same thing I'm hearing with fentanyl, that buprenorphine and Suboxone, which is more accessible, you can get prescription for those things, aren't really sufficient to take care of the fentanyl levels.
Yeah, that's what I was gonna say. I don't really have like a doctoral way to say it. Just on the patient side of knowing that, like, for as excruciating as it was to get through 3 weeks, knowing that I could just take methadone and feel well then, if I needed to use up until the day I could have, versus like you need to be sick and you need to be in pain to use Suboxone, right? Like so like other medications are just I wasn't getting through it. Like it didn't matter how much I tried. I tried Suboxone multiple times. And there was more diversion there because I had extra and it didn't work for me, right? So like instead of seeing if it did work for me and actually getting on it. But yeah, so just at that level. But I will say also working, in a detox for a long time, a good amount of time, especially when fentanyl was like really and still is so misunderstood. I think that at this point, like a lot of the dosing criteria is still back from like the old school heroin, right? And so like I hear a lot of, again, this like uneducated piece of like, oh, they're taking enough methadone to kill a horse, like all of these, like, don't start them higher because it's too much. And like in reality, like they're addicted to fentanyl, like they need that much, like we need to be starting higher, we need to be getting people comfortable, we need to be meeting them where they're at. This trickle-in effect isn't doing anything but prolonging the risk of overdose and crisis. So that's just what I have to say about the way that fentanyl, I think, has been really affecting methadone access.
Yeah, and just to add to that, I think one reason why lots of people don't stay at methadone clinics is because we are still sort of operating and dosing back in like the 1960s, where we're starting at 30 and keeping it at 30 for 5 days and then doing like 35 for another 5 days. That's just not working in this day and age. We as Caitlin's saying, we need to like get people to a therapeutic dose, quickly and of course safely, but we need to get with the times. And we're not doing that.
Yeah, and as a follow-up to that, something else that came through the chat, and y'all, if you have questions, please throw them into the chat. How do other changes in the drug supply impact this, such as xylazine, or just like how tricky our drug supply is now post-COVID? Anyone can answer.
I would say that we are constantly behind. Because as soon as we feel like we have some sort of understanding of what's going on and we're trying to innovate to catch up, the drug supply changes again. And so I think more so, you know, it's always been important and essential to listen to what people are saying on the front lines, and especially the people who are going this, the people who are using drugs and trying to get on methadone. We need more now than ever to listen to what they're saying, because if they're telling us that initial doses of 40, 50, 60 milligrams are not going to cut it, I think we need to really listen and also innovate to adapt those changes. And to respond to Kirsten's comment in the chat, strict regulations do make it really hard for us to innovate and adapt treatment. So for example, there used to be a federal requirement from SAMHSA saying that on day one, the most you can get on methadone is 40 milligrams. And I can't think of any other medication, once again, where it's literally written into law how much milligrams I can prescribe on of any medication. And so these regulations do tie, you know, where we have our hands tied behind our backs, where we're trying to catch up with a constantly evolving deadly supply. And I do want to shout out, there is our OTP in San Francisco in our county hospital. They have been trying to innovate, and so they've been doing more rapid protocols. And so we recently published a paper describing that practice, where we're able to get people, where we start people on 40 milligrams on day one because of, again, the federal regulation at that time, 60 milligrams on day two, and then 80 milligrams on day three. And then, you know, up to 100 milligrams if they need to within the first week. And so trying to get people on this medication as soon as possible, because we know that this medication saves lives.
And then as a point of clarification, someone asks if they are understanding correctly that given today's drug supply, daily dosing at 100 milligrams or over is the norm and needed. I'll let either anyone.
I will take a stab, and then Rachel, please feel free to fill in the inevitable holes. What our studies have shown when in the days of heroin is that people therapeutically need a dose of 80 milligrams to 120 milligrams in that window. There have not been updated studies that I have seen or have heard that show what is the therapeutic dose, quote unquote, for people using fentanyl. And most are relying on patient reports of what people are feeling and what people are experiencing. And so what I've heard is that people may need to get onto that therapeutic dose much faster to treat withdrawals. And they may need to be more on the sort of like the latter end of that spectrum, on the 100 to 120 or even higher doses than that. But everybody is so individual that you can't really say this is the dose for you. You have to actually listen to them and tell you, or have them tell you what they're experiencing.
Yeah, exactly. And I guess I will say, to add to that, the 80 to 120 comes from sort of like population level studies on like what dose do people get to a spot where their urine toxicologies are negative for opiates or things like that. And methadone, you know, I have a healthy respect for methadone, and because it's such a, it's metabolized so differently based on the person. There's just like a lot of different like enzymes and medications that can interfere with methadone metabolism. So I have folks here who have gotten stable on a dose of 300 milligrams, some folks who are on 40. I mean, the variability is really wide. And so that, but the population level of 80 to 120 is helpful for me when I think about things like that. And I also understand that these studies were done like 20 or 30 years ago when the supply was very different. And the daily dosing thing, I mean, I feel very fortunate now that when someone gets admitted to this program, I get to talk to them and like have a conversation, and we decide together like what dosing would make sense for us here to make sure you're safe, and that you're also like able to live your life. So I don't think daily dosing is like obligatory in any situation. If someone who comes in who's like 90 years old, like a frail old lady on oxygen, and I'm like, okay, I need to keep closer tabs on you. But you know, it's definitely a conversation that's like individual. So no one is, you know, off the bat needs daily dosing.
Yeah, and y'all have all started to kind of touch on this sort of imagining the OTP clinic as a different place, and different ways that even with the strictures, you're able to operate and dance in it. So I would love to hear what are, I mean, like Leslie already talked about this with the study that her and her team put out, but I would love to hear other ways that you've seen OTP clinics be really creative and be more person-centered.
I'll just touch really quick since I already did. I wish that I had the link so I could be tech savvy like you guys and throw it in the chat for everybody. But I can get it out there. The clinic that I'm at, the supervising clinician actually made up a tool. So she went out and she was like, how are we going to decide if people meet this criteria of substance use disorder? And realized that like all the tools that are out there are very outdated. We weren't getting answers that we needed. It didn't really make sense. And so she made this tool up by herself, well, and with the, you know, obviously all the team, but with the intentions of the first part of the tool is asking like how methadone has helped you. How does it improve your life? How's your recovery? Where are you today? Like, tell me about where you are. And then through asking questions about use and when and how much and those types of things and having those conversations organically, you can go down the criteria of the DSM-5, make a score, and then also include the final rule at the bottom of those types of risk factors, if you would. And then also a space as well for factors of what would happen if your take-home bottles were taken away, right? So like people who live far away or take care of people or these types of things, like their life would be changed dramatically, right? They can't hold jobs, all of this. So there's even a place for that. And so there's so now what they're doing is people that are on 13 or more take-home bottles, if they go for a while without a screen, that's positive, and then they are positive for a substance, they'll do this tool, they'll sit down, they'll have a conversation with their clinician, and maybe you go down a little bit on bottles, but it's very possible that you just stay where you're at, right? And you just have a conversation, which is really huge. And so just implementing, you know, different things like that to start having these conversations. It was really cool to be part of that and see, you know, that blossom at the clinic and see people, you know, still very worried about it, people still concerned, people still learning, but it's definitely going to be a learning curve and it's going to be a lot of educating pieces in there.
Thanks so much, Caitlin. I'm curious if Irene, you've seen anything in Arizona?
You know, again, like I mentioned, that the SOTA is willing to adopt the recommendations, but it really will come down to the clinics. One thing I'll say is that the largest clinic system does seem to want to adopt these recommendations. I go to a smaller clinic and I'm very frank with them and talk about, you know, these changes that are in the pipeline and eventually will start to happen. And they've been really reluctant to adopt the stuff. Like for instance, I'm still going 2 days a week and I've had clean UAs for a year. So you get, you have to have 3 months of clean UAs to get 1 day of take homes. And, but I tell them, you know, eventually people are just going to start voting with their feet, because if one of the clinic systems decides to adopt these 28 days, you better bet I'm going to switch to that one, you know. So we'll see. I guess October, pretty soon, we'll see what happens. But so far where I'm at, you know, I keep talking to them about it, but they're not making any noises. So.
Yeah, and I think that's interesting, right? Because it's like when we talk about negative or appropriate urines, we're not even just talking about opiates at that point, right? We're talking about the broader like drug use, regardless of whether or not for that substance you meet criteria for a substance use disorder. And so, yeah, I would love to hear like how, you know, especially like maybe like start with you, Rachel, about how you work within that of like people are going to use other substances and how you help people stay on their methadone and like maintain this kind of flexibility in light of kind of a rigid UA system.
Yeah, I'm fortunate in that I work in a progressive clinic where a urine toxicology that's positive for some substance doesn't automatically mean that take homes are getting taken away or something. I think there's an argument to be made that why are we checking substances that are not related to, you know, methadone treatment, right? Like I'm not expecting methadone to be treating someone's cocaine use disorder if they have it. So I don't know why I'm checking cocaine. And until very recently, we had THC and alcohol on our urine drug screen, which, you know, just doesn't give me a lot of clinical information and is not useful. So there's like a lot of stuff checked on the urine drug screen that is sort of a waste and just contributes to harm. And yeah, I guess I just try and approach, you know, if someone has a you know, someone comes to me and wants to be on methadone, what the Liberating Methadone Coalition has really taught me more than any other education I've got is that methadone is, the medical model of methadone is something that deserves to be paused. And some people get on methadone for very different reasons. And I am not one to really judge or put a hierarchy on why someone's getting on methadone. And if I can improve their quality of life and get them safer and doing the things they want to do, I don't really care about a urine drug screen. And I really don't think we should be putting that much importance on it. So unfortunately, that's not the world we live in, but there needs to be a lot of nuance to urine drug screens. Yeah.
Yeah, and as you had stated earlier, we don't do this for any other drug that also reduces mortality by half.
Yeah.
And that setting these standards is, like, in my mind, what I'm hearing is it's really rooted out of fear and stigma than it is out of patient-centered care. So I know we only have a couple minutes left. Real quick, people, if anybody's interested in methadone advocacy and reform, we at Liberate Methadone welcome you. If you have any interest at all, you belong with us. So feel free to go to our website, sign up. I think there's somewhere a link in the chat. But lastly, I'm going to ask, there's a really interesting question that I liked, particularly related to peer support specialists. I'm going to kind of expand this to even like social workers, everyone who works in this methadone system, who by virtue of working in it is somehow beholden to the harms that it does, like even when we're trying to make change. And somebody asked, like, how can these people function authentically in these environments and provide the people who are entering these spaces with the care that they're needing and asking for? I'll let anyone answer.
I just want to quickly just take a moment to say that I have a role as a recovery coach. And so being in this position of being on methadone and being a recovery coach, there's still a lot of stigma. Like I wasn't allowed to tell my recoveries I was on methadone. And like, you know, there's a lot of this unauthentic piece of being able to really meet someone as a peer and be like, this is what I'm doing and this is what helped, when there's so much gatekeeping still happening because of methadone. And so that's a really challenging question when I hear it, because it's hard for me to live it daily. And it was a struggle that took me a lot of years of getting through it, and a lot of job interviews that I was denied as soon as I said I was still on methadone. And they said, what? You said you were in recovery? And they instantly stopped my interview. And so there's still a lot of stigma around MAT, MOUD. And so being in this peer specialist role, it can be hard to have those authentic conversations, and as well as advocate for people to get on these medications, because sometimes I feel like I'm setting them up for failure, unfortunately, with the way things are set up, with the way your life is taxed, with the stigmas that come with you being on MOUD, the stigmas you face from other people in recovery. I sometimes feel like I'm setting them up for something that they might not want. And so it can be challenging from this.
I'll just add that I briefly worked at one of the larger clinics here I was an employment specialist. I was helping people find jobs, but I would have a lot of conversations with the peer support workers. And most of these people are great and they're doing such difficult work. And I often think they get taken, peer support workers generally get taken advantage of and all that stuff, not paid adequately. But what kind of would surprise me is the variability in attitudes among the peer support staff. And there were a good number who are very firmly involved in the 12-step and would espouse that with all the clients and stuff, to the point of even kind of talking down Matt and stuff while working in the methadone clinic. And I think that's fairly common that a lot of, I mean, anecdotally, that a lot of people who work maybe in the clinic system or recovery generally are people who have maybe gone through, you know, traditional 12-step recovery themselves and are really psyched about it and want to evangelize. But I think hopefully more recently we're starting to see more of a patient-centered, less strict abstinence-only based mindset. But I still see a lot of that old school 12-step going on. Not to trash 12-step. I just,
no, I hear you. It's like we need, in the same way that we have multiple medications to treat depression, we need multiple treatment options to adequately like support people. Like we never expect one pill or one medication to cure it all. And yet here we are expecting probably too much of any individual treatment program. Okay, we have 5 minutes left. I would love to hear from each of our panelists. What is a way that, like, leaving today, somebody can go and advocate for methadone change in their community? Start with, right, Rachel.
I'll go first because if I go last, we'll run out. I think one way to advocate for change is to get to know your SOTA, your state opioid treatment authority. And as Dr. Ruth Potee will say, just tell them to stop adding on state regulations to the federal ones. Because the federal ones, like, you know, it's the states add a whole lot of barriers. So if we can tell our SOTAs and convince our SOTAs to align with federal regulations, I think we'd get very far.
All right, Irene?
Yeah, I think that's a great idea. I know that one thing that I think somebody in the chat touched on the MOTA bill that did not pass, but when that was being considered, I'd come up with this script and shared it with friends and family to send to representatives so that they would vote for that thing. So I think that, you know, but even more generally, just educating people in your day-to-day life about, because all the stigma around methadone just comes from a lack of education for a lot of people. They don't really understand it because it's so secretive and ensconced in these clinic systems and kept under wraps in this weird carceral system. So just educating people, I think, is always a good plan.
Caitlin, we'll turn to you.
I know for myself, just as a patient, getting involved with like patient advisory councils at the clinic, starting patient groups, getting a seat at the table for us. It's been a long time where we haven't had that seat. And so I think being able to have our voice there is first and foremost. And my own little like personal tidbit is I've just been trying to be as authentic as I can be, learning that I'm not doing anything wrong on MOUD and it's saving my life and it's saving thousands of others. So sharing that proudly instead of hiding in it as long as I did is just the couple of steps that I can say.
All right, and we'll turn to you, Leslie, to take us home.
Yeah, I would say find your community. I think that advocacy is a team sport, and we've already talked about how the system is such a behemoth that has so many different challenges and problems, and it's not going to be fixed by any one person. And so find your community. There's so many groups out there. MATSA is one, National Survivors Union is one, if you're someone who is on methadone or a person who uses drugs. And then, you know, the National Coalition to Liberate Methadone has been mentioned multiple times, and welcomes anybody who really wants to work on improving our system of care. And so really, really think about who your community is, and because it energizes you, and make sure that that you can fight the long fight. Thanks.
Well, thank you all so much for this really interesting and important conversation. And I will say it again, come join us at NCLM. All right, I'll turn back to Kirsten.
Thank you so much, Kate, and just so much gratitude for all of the panelists and this really rich discussion. You all, we are grateful for your depth and breadth of expertise on this issue, but also just a lot of the humanity and the nuance that you brought to our understanding of this system. So thank you, thank you. One piece of housekeeping, my colleague Juan is gonna put a link in the chat to a brief survey, just to hear some of your feedback from the session. And we'd be really grateful if you could take a couple minutes to fill that out, because it helps us communicate the value of this work and continue to fund these sessions. So thank you for that. I know I mentioned this is part 2 of unknown, more sessions in the series. So we're still kind of finalizing the details on those, but stay tuned for part 3, 4, maybe 5. And we can talk about, kind of pick up where we left off here about what are some practical changes to the system that we could advocate for, and how can we kind of dream of a different vision, different kind of space for people. So thank you, everyone. Have a great rest of your day. We'll be sending out the recording to all those who registered. Thank you again to our panelists.